And good evening, everybody, and good morning, Dr. Suresh Reddy.
Good morning.
So, yeah, uh, so um, we know there are the importance of opioids in pain management. And in India, we have a few opioids available, but we have to understand that there are many other opioids available in various parts of the world. So I think the most suitable person would be Dr. Suresh Reddy to talk about that. Um, so presently he is the professor of Department of Palliative Care and Rehabilitation Medicine in the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center. And he completed his MBBS from Hyderabad, and then he went to UK and US, and he is a American board certified in anesthesiology as well as in pain management and also in hospice and palliative medicine. Then he held various positions in various hospitals, but mainly in MD Anderson Cancer Center. Uh, um, and presently, he is also the member of Community Hospital Education and Training to Improve Palliation Standards Advisory Group Committee, the Education on Palliative and End of Life Care Project in Chicago since 2010. And he is also a member of various committees in the institutions. And he has received many honors and awards. And the latest one was in 2018 for the Faculty Achievement Award in Education by the William Randolph Hearst Foundation. And he has membership in various professional bodies. And he has published, I don't know, maybe more than 50 publications. And there are many book chapters. And he also wrote in invited articles. Then, yeah. Moreover, that he's a person who knows about the situation of palliative care in India, and I have been privileged to be one of his not student, but I was able to hear his speech many times when we were students, and later after that. So, with that introduction, I welcome Dr. Suresh Reddy, and it's over to you.
Thank you, Sunil, for that sweet and nice introduction. Good evening, everybody. I never spoken to a group in the evening about opioids. I guess it's a fitting lecture. Because after this talk, during and after the talk, you can doze off. So it gives me great pleasure to come back and address Pallium India Group. I've been working and coming to India since 2002 as a palliative care specialist, and I learned so much in the process. I learned more than I could give to various parts in India. So I've been associated with Sunil for many years, almost 2 decades now, and the Trivandrum Palliative Care Group and other groups in India. So I work closely. I know a lot of players there. So I'm not going to give you a lecture with a differential, with America and India and things like that. So I know a lot about opioids in India, and we talked about methadone first in 2002 in Hyderabad. That's where I was first introduced to India, and then later on it got approved, and now it is being used in India. So we are going to today talk about opioids that are not available in India. It's very difficult, right? I mean, to comprehend any opioids you are not using. But I would, instead of doing that, I thought I would discuss that in terms of, going back to, mechanism of opioids And the thing I'm really, really interested to teach and to share with people is to talk about metabolism of opioids. I think that's the um, uh, core thing that we all need to understand to use opioids. Sometimes we forget that. And if you understand metabolism well of different opioids, then it becomes very easy for you to prescribe and use opioids. So that's where we're going to stress a little bit. And in the context, I'm going to introduce you to some opioids which are may have availability in some states, but not widely, and see if they are useful to come to India. So let's start. Let me share my screen. Can you all see my screen? Yes, thank you. I have no relationship with pharmaceutical companies. I don't go and give talks based on pharmaceutical company sponsorships, nothing. So these are the objectives for today: basic science of opioid, and then metabolism of opioids and individual opioids, especially the ones which are not available. And if you have any questions on any opioids after this talk, I'll be happy to answer, and we can share and exchange knowledge about them, your experiences and my experiences. So I want this to be an open dialogue rather than me telling you this is what it is. I believe that you've all been doing palliative care, so you're all experts. That's why I asked Neil last night, what is the breakdown of participants. So I'm glad about that, because I really prepared the lecture for people who have been doing palliative care. So I think it will be a nice session for both of us. So let's look at the opioid receptors in the brain, in the spinal. These are present in different areas in the brain, starting with the spinal cord, going to the midbrain, medulla, pons, and then frontal lobe. And then look at this amygdala. That is a part of the reward center in the brain, limbic system, which again, when you take opioids, has a lot of interaction and releases dopamine and whatnot, and give that reward, that happiness that you get from certain drugs. And that's where sometimes we end up in trouble, because then opioids are taken for non-medical use to treat others other than pain. So when the limbic system is involved, we all know this is a reward system. So there are receptors there too. So type of receptors, mu are the common receptors, mu opioid peptide, what we call. Then we have kappa, delta, and this NOP2. But we mostly would like to concentrate on mu opioid peptide. That's relevant to us. Some on kappa, delta not as much. But we'll go into a little more detail into those later. There are also different subtypes. For example, MOPs have mu1 and mu2, and there are 3 KOPs and 2 DOPs. Not that much relevant, but mu1 and mu2 become relevant to us. Basic mechanism of action, again, in all the centers is they activate descending pathways. Again, site of action is midbrain and the medulla, including dorsal horn. The descending pathways coming and inhibiting pain. And then there is an ascending pathway going into thalamus and cortex. So they work on both pathways. And finally, basically the idea is to inhibit pain signals. Okay, the inhibitory pathway, ascending pathway, it happens in inflamed tissues in the periphery where the opioid receptors are generated, in the dorsal horn and in the thalamus. And these are the descending pathways, the ones in red. So that's how they work, opioids. Okay. So 1 second. Yeah, there you go. The mechanism of action Basically, opioid receptors bind a G protein here. When they bind, they kind of activate this G protein, which inhibits cyclic activity, cyclase activity, the enzyme. So the concentration of cyclic AMP is decreased. When that is decreased, there is calcium entry is blocked. At the same time, the potassium channels open and potassium goes out. Okay, so the concentration of calcium is decreased. So the neurotransmitter release is decreased. That's how they help with pain. And most of it work in the presynaptic receptors, but some in postsynaptic too. And both mechanisms, potassium and calcium, they happen at both presynaptic and postsynaptic, mostly presynaptic. And this efflux of potassium causes hyperpolarization and inhibits transmission. That's all. And these are some of the chemicals which are inhibited. And as you see, when the potassium goes out, this is hyperpolarization. So the stimulus needed to get action potential becomes even more. So you need more stimulation to get that. So that's how the impulse is kind of gets negative, and that's how you get pain relief. So that's hyperpolarization. So after that small mechanism of action, how it works, we know exactly how they work. And then let's go to the actual opioids and how they're classified. Depending on origin, how they're made, they can be natural, semi-synthetic, and completely synthetic. Okay, synthetic ones, people make in the backyard, in the labs, very easy to make. Natural ones, of course, we have to grow plants and extract, like we have it in Ghaziabad, and in India is the biggest manufacturer of opioids, morphine. And then depending on the intrinsic opioid receptor activity, how they when they go and attach to the receptor, what kind of effect it elicits. So based on that, they're classified into pure agonist, partial agonist, antagonist, and agonist antagonist. Okay, I will briefly touch base on that. Then analgesic potency is they can also classified based on potency. That's strong effect, intermediate effect, and weak effect. What we call in WHO ladder as strong analgesic and weak analgesics. This is how it is based on. So natural alkaloids are derived from papaverum, this milk juice you see here. That's what it is derived from. There are many substances in it, but we are interested in morphine and codeine. That's how they're derived. This is a 5-ring phenanthrene. If you look at it, 3, 4, 5. Okay. And then this is where most of the opioids are derived from. And I'll show you a slide about that. So modification of functional groups make it a different opioid. For example, this is heroin, right? To diacetyl, acetyl groups are here on these 2 rings. This is a basic structure of morphine. Okay. Then, depending on the change in the ring, it becomes oxymorphone. And then, again, change in the ring, one site becomes oxycodone. And remember, look at the oxymorphone and oxycodone. They're pretty related, except for this change here. So that's why sometimes when you give oxycodone, which is, I think is not available in India, except in some states, it is converted into oxymorphone. So they're very related. And morphine, again, there is a ketone here that change, and that becomes hydromorphone. Again, not available in India, but they're related. Morphine and hydromorphone related. And both oxycodone and hydromorphone are more potent than morphine. This is about 1.5 times more potent. And morphine is, if depending on which table you are looking at, anywhere from 5 to 8 times more potent than morphine. Because the more lipophilic they become, the more potent they are. And then you have hydrocodone, which is different from these, but it is a little bit related to hydromorphone, because hydrocodone, again, is not available in India. It is converted to hydromorphone. It has to be converted to hydromorphone to become active. So these two are related. These two are related, and morphine hydromorphone are related. Okay? So there's a small change in terms of active moiety change the chemical, and that's how we got so many opioids. So we have morphine in India, and we don't have oxymorphone. I don't think oxycodone no, hydromorphone no, hydrocodone no. So of the natural opioid, we have this morphine. Okay, and yeah, let's talk about this a little bit. So the progressive reduction in the number of fused rings in the phenylephrine moiety will make different opioids. For example, synthetic ones, levorphenol, and then you have meperidine, which is pethidine in India, which is not used for cancer pain. Fentanyl, then anesthetic, very strong opioids like sufentanil and alfentanil, and then methadone, which we use now commonly. And propoxyphene used to be used in India when it started. Very good. We used to call it a poor man's methadone, but it is withdrawn from the market now. So most opioids act at the mu receptors. Okay, mu1 because it gives you analgesia and euphoria. Mu2 mostly sedating, like respiratory depression, sedation, decrease GI motility, and causes constipation and meiosis. And the delta and kappa receptors, they do cause analgesia, but they do cause dysphoria and psychomimetic effects on the brain, like delirium and not a pleasant feeling. Then they have affective behavior, meaning they can be prone to addiction and habituation, and they can be pro-convulsant, especially delta. We don't have many delta agonists though. They do not cause respiratory depression or decrease GI motility, they claim. So that's why they might be slightly popular. For example, buprenorphine that is used in India is one such agent. So intrinsic receptor activity, pure agonists, they bind to receptors very strongly and demonstrate high intrinsic activity at the cellular level. That's it. They don't do anything else with the mu receptors. Then partial agonists bind to opioid receptor but produce a sub-maximal effect compared to pure agonists. That's the difference between partial agonist and pure agonist. Antagonist is basically has no intrinsic activity but attaches to the receptor. So it displaces the mu pure agonist chemicals and cause antagonism. And mixed agonist antagonist is same chemical can work as an agonist on one receptor and antagonist in another. So that's why they're called mixed agonist antagonists. That's why we don't really use it in cancer pain management, because they can cause withdrawal and confusion, pentosacine and things like that. Unless then other opioids are not available, we have no choice but we use them. Any questions so far?
Just one clarification. Dextropropoxyphene, the use was suspended long back, but 2 years back, it has come back into the market with a specific indication for treating cancer pain.
Okay. Well, you have it available now?
We are not using as of now. We don't use the dextropropoxyphene.
But remember, Sunil, when I started, we used to use that. In fact, we wanted to do research on that compared to morphine, because we thought because at that time methadone was not available. So I thought oxygen came close to that as a drug. But now we have methadone. So I'm glad actually we have it available. I know you're not using it, but I'm glad at least it is there.
Sir, is this dextropropoxyphene the same in this cough syrup, sir? Okay, that is dextromethorphan.
It's a dextromethorphan.
Sir, does Ruson Pharma give this dextropropoxyphene, sir?
Sunil, who makes it? I don't know that.
No, I don't think it is Rusan. It is somebody else.
Okay, sir. Sir, how can we compare it to methadone, sir?
Pretty similar, actually, believe it or not. Very similar. And it has a cardiac effects too, but methadone also we're discovering that it increases QT, but it's overblown. Otherwise, it works really good. NMDA receptors, mu receptors, and things like that. It used to be very good for combination pain, somatic and neuropathic pain.
Sir, how can it be compared to morphine, sir?
Morphine is a pure agonist, right? And it only works on one receptor type. Whereas propoxyphene, like I said, works on more than one receptor type.
Okay. So the potency or this, it will be better than morphine.
Probably, yeah. Even though I have not used it. So
Okay.
Sunil can tell you better about that than me.
Okay.
But we did, when I initially used it, at least for 1 or 2 years when I visited, and then it's gone. So we have not used it, and I can't recall exactly. But Hyderabad group I talked to, they were very keen on that, especially in the cervical cancer, when you get a lot of pelvic mass and lumbosacral plexopathy pain and things like that. They used to use it a lot and claim that it worked really good.
So why it has gone out of market?
Because of cardiac effects, I think.
Okay.
So when you use an agonist antagonist drug, won't there be opposite effects from the same drug?
Same drug, it depends on the intrinsic activity, right? How much antagonist activity it has, how much agonist activity it has, it depends on that. But we found that, most of the agonist antagonists, like for example, pentazocine, provides good pain relief. The problem comes when you try to use other agonist with it, because it has ceiling effect. And if you want to get a better pain control, it works to some extent. But if you want to get a better pain control, progressive pain in cancer, then they are no good.
So if you use morphine with pentazocine, that will adversely affect, isn't it?
Adversely affect, yes. And you have to withdraw, of course, agonist, antagonist, and then use morphine. I think the more problem is when the patient is on morphine and when they want to use these, opioids, agonist, antagonist, you get reversal.
Okay.
That is the more of a problem. Yes. And if they are on agonist, antagonist, and if you're trying to use morphine, you can slowly withdraw that and then introduce morphine. Then we don't see much of a problem. Yeah.
Thank you, sir.
Yeah. Thank you. All right. So, I'll stop, in between, and we can have what we call micro discussion in between. And then at the end, we can also have a big discussion. But let's go ahead now. You gave me 1.5 hours, Sunil, right?
Yes.
Okay, that's good. That's good. So the full agonist examples are these on the left. That they are like pure agonists. And we have fentanyl we use. Is levorphenol available in India, Sunil?
I think it is available, but no, I haven't heard from anybody that they are using. But I think I heard that it is a very good medication.
Excellent.
Without any side effects. Yeah.
I think if it is available and it is affordable, my God, it's a great drug. And recently, a group, my colleague Akila Reddy did a study on levorphenol and worked exactly like methadone, but no, you don't have to worry about QTC prolongation and nothing. It's a great drug. Yeah. I think I need to talk to Raj Gopal to see the status of that. But I think it's a great drug. It may come back. It's not coming back here because it doesn't make any sense economically. That's why pharmaceutical companies are not keen to introduce this, but they're trying. So it's not covered by insurance companies. In US, everything is whether insurance approved or not. That's what we practice. But levorphenol in India will be great addition, I think, in future. Meperidine, you all know, but we don't use it. Methadone, we all know. Morphine, of course, is great. And oxycodone, oxymorphone. Other two drugs which we commonly use in the United States are pure agonists. Partial agonists are buprenorphine and butorphanol, pentazocine, tramadol too, and use tramadol a lot right in India. Also partial agonist. Mixed agonist, buprenorphine, same drugs, and antagonists, of course, naloxone, naltrexone, and others are coming too. So just a table to show which one works where. Pentazocine on mu is partial agonist, kappa agonist. Nalbuphine is antagonist on mu, kappa agonist. Buprenorphine partial agonist on mu, but it's antagonist at kappa and antagonist weak at delta. Butorphanol is antagonist on mu and partial agonist. So if you use butorphanol with other opioids, it's no good because it's a mu antagonist. So they demonstrate ceiling effect, meaning after a certain dose, they don't give more effect. So there is a plateau. And then they precipitate withdrawal symptoms. Then they cause dose-dependent psychomimetic effects because they're agonists on the kappa. Not spend too much money on this. With their high affinity for this, naloxone and naltrexone are two opioid antagonists, and they're very popular in opioid overdose. But unfortunately, they are sometimes misused in emergency rooms, and somebody comes with sedation on any opioid, even whether they are on it for a day or 1 year, they slam naloxone first. That's the teaching, right? In emergency rooms in medicine, every time a patient is on opioid, and if they have, they're not breathing well, then give naloxone. It could be from other causes too. That's what we see again and again. Naloxone is abused a lot in patients with opioids. So you need to be careful on that. But now we have a lot of opioid epidemic in the United States, and we are giving away this nasal naloxone freely to patients and families just to keep it on hand in case they get overdosed on that. But I mean, I've seen disasters from injecting naloxone in people who have been on opioids and then brought to the emergency room, and you give naloxone. It can cause myocardial infarction, can cause pulmonary edema, and very bad withdrawal symptoms if you're not careful with it and how you administer it. Naloxone, naltrexone. Also, this is available orally. Naloxone also is given orally, but same injection you ingest, but bioavailability and effectiveness is not as great as this one. And it's a long acting too. Naloxone doesn't work for more than 30-40 minutes, and you have to observe the patient and probably repeat it if they're really overdosed on opioids. So this is a topic is of importance. I always teach this first every time a new person walks into palliative care, because once you understand metabolism, then you understand drug interactions, and then which one to use where and how to use one particular drug in liver issue, kidney issue, and things like that. So let's spend a few minutes on opioid metabolism. So opioids are generally well absorbed when you take orally. That's why we prefer that we give orally, and then you can give more, IV at home. So oral is a preferred. In fact, if they have to tolerate oral before they go home, if they're admitted to the hospital. But majority of the outpatient we see are belong to outpatient, depending on their function, of course. The morphine, hydromorphone, oxymorphone, they all undergo first pass metabolism, meaning they're extracted a lot in the liver. They are metabolized in the liver. There's the first pass, is the pass to the liver first. And then most of them cross placental barrier, and they affect fetus, of course, in pregnancy and all that. So you need to be careful. Metabolism is by in the liver, most of them, by hepatic enzymes. They're inactivated by glucuronide conjugates before elimination from kidney. And that example by glucuronidation is morphine is converted to morphine 6-glucuronide, which has analgesic properties. And also it's converted to morphine 3-glucuronide, which has excitatory properties. So sometimes that's why when you give morphine in people who have impaired renal function, these two metabolites can accumulate. And as you can see, they're both active. One causes more analgesia and sedative effects, may lead to respiratory depression if we keep on giving morphine in altered renal patient. And also M3G glucuronide can give rise to myoclonus, hallucinations, and delirium and things like that. So both ways it's not good. So one mechanism is what we call as the phase 2, which is conjugation. So metabolism is basically what happens is the enzymatic conversion of a drug, which converts into more water-soluble compounds, so it can be excreted in the body fluids such as urine or bile. So that's the basic mechanism of metabolism. Occurs mostly in the liver, but it can also occur in the gut wall, lungs, and plasma too. Okay, two types of metabolism, very important to know. One is phase 1, which is also called as a modification reaction, and phase 2, which we have just talked about, is a conjugation reaction. Some very few drugs undergo both, though. So let's look at the phase 1, which we are really interested in, because it is basically it's subject to oxidation or hydrolysis. That's what happens. And main enzymes which do that is what we call as a P450 enzyme system in the liver, which contains like cytochrome 3A4 and cytochrome 2D6. There are also other cytochromes, CA4, CA8, CA7, but most commonly by CA4, where methadone is converted, and CYP2D6 also is important. We'll talk about that in a minute. But we need to know these two for sure, 3A4 and 2D6, okay? CA4 metabolizes more than 50% of all drugs. Because it is cytochrome system, any drug which depend on metabolism of this enzyme can cause interaction, because they compete when you're giving drugs, two drugs at the same time, which compete for this. For example, when you're giving methadone with antifungal, and they both compete for this enzyme, and both drug levels go up in the body. And that's when you end up in problem. Or when somebody is on methadone or antifungal medication, when you give methadone or antifungal to one or the other, then you need to be cautious, because the drug level will go up because they're competing for the same enzyme. So that's something to remember. So phase 1, drugs which undergo phase 1 metabolism can interact with other drugs. That's when you need caution. Okay, and there are many other drugs, not only in pain management. There are other drugs which you need to know that we use in palliative care, which undergo phase 1. And then there is this second enzyme is 2D6. Very few drugs are metabolized, but there are drugs which are metabolized. I'll show you the one which you use in palliative care. They're intermediate risk, and 2D6 is an enzyme. It depends on to some extent genetics too. There may be absence of the enzyme in some races. There may be lot of enzyme. They're ultra metabolizers, slow metabolizers, and so on and so forth. It has implications. So, for example, codeine, phase 1 drugs which are metabolized by these enzymes are codeine, which we use in India, hydrocodone, oxycodone, fentanyl we use, methadone. So for India, it's fentanyl, methadone, and codeine. Takes important. And hydrocodone and oxycodone, which you don't have, and you probably don't need these, are also metabolized by phase 1. Okay, something to remember. Phase 2 is easy, and these are conjugation reactions, mainly glucuronidation, no involvement with cytochrome system. Okay, so this is a minimal drug interaction when used. That's why morphine is popular, because you don't have to worry about adding or taking away other medications, because it is phase 2. However, you need to worry about morphine because in renal issues or in dehydration, pre-renal uremia and things like that, you remember the metabolites of morphine, 2 active metabolites, they can accumulate. That's where the problem is. Problem by itself, but not, we need to worry about interacting with other drugs. So that these 2 phases are very, very important for a palliative care physician to understand very clearly metabolism of opioids. Then you can feel comfortable And you need to know which drugs are metabolized by phase 1 versus phase 2. Okay. So the morphine we use is phase 2. Hydromorphone, which you don't have in India, oxymorphone, you don't have. Livorphenol, if it comes in future, is also phase 2, as opposed to methadone. So that's why livorphenol is probably the more promising drug in future. It's an old drug, really, but we'll see. I mean, I'm not sure it's that easy to get it into market, but we are struggling, so I'm not hopeful. But it is there. So. Any questions on that? Because that's very, very important.
Sir, regarding this morphine metabolites, what you told about, when we have some CKD patients or somebody, in what test should we do to find out toxicity, or should we go only clinically?
Yeah, so yeah, you have to go clinically. It's not an absolute contraindication, by the way. Okay, you adjust the dose. We cut by 20%, 30%, 50%, depending on the clinical scenario and the creatinine and things like that. No, there are some guidelines, but not clear guidelines about how much reduction we should do. But mostly we go clinically. Okay.
This urine test, anything is there, sir, to see?
Urine test is not there to find out side effects, right? So urine test, you can measure, M6G and M3G, but that's expensive and takes time, and not sure that gives you too much of anything. There's no urine test. Urine test is useful only to see if morphine is detected and metabolites are detected. That's all, and that is used mostly for people who claim that they are taking morphine, but they're not. They may be selling it, diverting and selling it. And that kind of situation, you do urine, what we call random urine drug screen, and that will tell you whether they're taking it, they're compliant or not. Other than that, I don't think it's useful.
So for toxicity related things, it is not useful.
No.
Okay.
No.
Thank you. Thank you, sir.
Yeah. Okay. So opiate that undergo phase 2 metabolism. So this is a morphine. You're very, very familiar with. It undergoes phase 2, glucuronidation. These are the enzymes, metabolites we talked about. So in renal elimination, that's why any altered renal function will accumulate these two products. So this M3G is not reversed by naloxone, by the way. So this is a conservative management, switching from one opioid to other. That's where we do commonly. Okay. And since they're not cytochrome C enzymes are not involved, the drug-drug interactions are not common, but accumulation in renal failure is common. Of course, in elderly and the dehydration situation, you need to watch out. I think there are many scenarios I can think of in India. Classically, I used to see all the time cervical cancer patient, pelvic tumors, ureter is blocked, and then there is altered renal function, increased creatinine, uremia, and people they don't need much morphine; they need a little bit because it hangs around in the system for a long time. So that's when you need to be cautious. So you need to know which kind of tumors and which kind of compromise on the ureter can give rise to this, and you're careful. That's all. Hydromorphone is a drug not available in India, and topic of today is supposed to be this. But without understanding, the background and all that, I thought it's very difficult to explain the opioid which you are not using. I told you already it's related to morphine, but it's more potent. It's a ketone, right? Hydrogenated ketone in that ring you saw. It is semi-synthetic, more lipophilic. That means it's more potent and absorbed quickly than morphine. You have short acting like morphine and long acting also in here. It undergoes phase 2 metabolism like morphine. But unlike morphine, it has only hydromorphone 3 glucuronide, meaning it can still cause neuroexcitatory side effects like myoclonus, hallucinations, seizure, allodynia, what is called as opioid-induced hyperalgesia, and it accumulates in renal failure too. Okay. But there are some papers which say that it's better than morphine because it does not have hydromorphone 6-glucuronide and any active metabolite. So, but M3G can be nasty too in here. This is a very, very, very popular drug in the United States, and especially the IV form, very commonly used and abused. So sometimes patients, when they're admitted, they only demand intravenous hydromorphone, and it's given rise to a lot of non-medical opioid use and the whole thing. It does work. It does work based on a lot of research in the emergency room. When patients show up with acute pain situations, fractures, and things like that, they did research on 1 milligram plus 1 milligram of hydromorphone reduced pain tremendously. It's a great analgesic, but it has these effects also. It might be very useful in India as an alternate to morphine. When you have problem with morphine, it's kind of switching from one opioid to another because it's more potent. Might have a place. It's not expensive. It is semi-synthetic. So if I have to bring, this might be a useful addition. But again, I said this is more potent and more lipophilic, and it's available in every form. You know, you can including you can give subcutaneous, intravenous, suppository form, oral, tablet, liquid, and we use this a lot here. This is one drug which is not available in India. Oxymorphone is another such drug, which is again not available in India. It's a derivative of morphine also. But I said oxymorphone and oxycodone are a little bit related. So this is semi-synthetic mu-opioid receptor agonist. Okay, its active metabolite is oxycodone, and it undergoes phase 2 metabolism along with morphine and hydromorphone, and it forms oxymorphone 3-glucuronide, likely inactive, and this is active. 6-hydroxymorphone is active. We don't use that much, but our group, again, my colleague Reddy did a study on this, using this in people who have small bowel obstruction, and we can give anything orally and long acting. So she used oxymorphone in a liquid form and gave every 8 hours. And it has both long acting and short acting forms, but the short acting you can give for every 8 hours. And and she had a paper on that, oxymorphone in small bowel obstruction. It was useful there. It's again useful as an alternate to morphine. It is 3 times more potent than morphine. Okay. It does not involve cytochrome system. It is a glucuronidation. So it has half-life of 6 to 8 hours, but it acts rapidly in 30 minutes. Okay. It is a long-acting form also, and the pharmaceutical companies marketed that as you can't tamper into it and things like that. That they had a special coating, so people can't extract drug from it and all that. But it proved to be not so good. It's withdrawn actually. That formulation is withdrawn, but you still have a long-acting and short-acting oxymorphone available. So slightly different, but not very different from morphine. It's 3 times more potent, available in tablets and oral and everything else. It's not available in parenteral, intravenous, and subcutaneous. Okay. So the 2 drugs we talked about, hydromorphone, commercially it's called Dilaudid, Diluadid, Dilaudid. And we also talked about oxymorphone. Commercially it's called Opana, Opana. So let's go on and march on to drugs which undergo phase 1 metabolism. Very important. Codeine is one such drug which undergoes phase 1. In fact, this is a prodrug, and we mostly use for moderate pain and cough, right? And this is like a phase 1 and 2 metabolisms to some extent. So phase 1 metabolism is mainly 2D6 and it's converted into morphine in the body. That's why it becomes active. And also 3A4 to norcodeine and the mild glucuronidation to codeine 6 glucuronide. So 2D6, remember, it's lacking in some people. It's absent. This enzyme is absent. So when you give codeine, mostly about 5 to 10% of Caucasians and 1% of Asians, it's autosomal recessive. You lack gene. So when you give, it's not effective. It's not converted into morphine. So you need to be aware of that. And also, if you give with 2D6 inhibitors, there are some medication that we use in palliative care, like haloperidol, paroxetine, antidepressant, fluoxetine. They all inhibit 2D6. They are inhibitors and excitators, and we'll talk about that in a minute. When you inhibit this, and there is codeine is not converted, right? Because the 2D6 is low, codeine is converted in small amount, or maybe not. So that's why it doesn't work in people like this, or it becomes ineffective. Let's put it that way. Then there are, ultra rapid metabolizers. And I think they found that in children in parts of Africa, where they metabolize codeine rapidly because they have a lot of 2D6 and rapidly they metabolize and convert into morphine. And there are deaths associated with that because they're rapidly converted into morphine. They are called ultra rapid 2D6 metabolizers. So you need to be something to remember about codeine. I don't know the numbers in India. I couldn't give you, I couldn't find, but I'm sure we do have some percentage of people who do all this, lack 2D6 enzyme and ultra rapid metabolizers too. So good bioavailability, about 3 hours half-life. So that's codeine. I just put it codeine because you use it a lot in India, but you need to know this drug interactions and metabolism and things like that. Hydrocodone, because codeine and hydrocodone sound same, but they're different. It is a semi-synthetic opioid. It is metabolized by phase 1. It is converted again to norhydrocodone by 3A4 and hydromorphone, which is the drug we talked about, right? After morphine, stronger than morphine, hydromorphone. So it is converted into hydromorphone in the body. Like codeine converted to morphine, hydrocodone is converted to hydromorphone. It is more potent than morphine. It's almost 1.5 times more potent than morphine. And then since it is converted to hydromorphone, when you see hydromorphone in the urine, people get excited. But if you don't know that it's converted into hydromorphone, you can label them as saying that you're taking this hydromorphone without telling us, kind of deal. So you need to really exactly know. That's why metabolism becomes important when you're doing urine drug screen. And we do this at random in the United States because we have this issue about opioids being misused sometimes. So that's when it becomes important. Okay. Same thing. If you have ultra rapid metabolizers, you'll get higher levels of hydromorphone, which is this one. And then you get more analgesia, sedation, and respiratory depression, things like that. There are poor metabolizers too. Then you get inadequate analgesia. There are some subgroup of people who give hydrocodone, doesn't work. That's why. Then if you inhibit CD6, then you get inadequate analgesia. So hydrocodone, like codeine, also follows these CD, cytochrome system metabolism. And is it useful in India? Probably not. It probably will not have much. And also it has this metabolism issue and interaction with drugs and things like that. And I don't think it's cheap. And it's good to have to rotate from one opiate to another, but do you need that many? I'm not sure. Is a compelling reason to bring it in India? I don't think so. It has been considered a weak opioid for a long time. So it is considered between codeine and morphine. So you used to say weak. So 10 milligram of morphine, we used to give 10 milligram of hydrocodone. But when we discovered that it is more potent than morphine. It's 1.5 times more potent than morphine. In fact, we used to think it is 10 times weaker than morphine, but it's turned out to be the other way around. So that's hydrocodone. It is also famously called in the United States as narco. NARCO, narco. So oxycodone, again, is a semi-synthetic opioid with agonistic activity on mu, kappa, and delta receptors. Okay. So kappa receptor activation in animals and humans produces anxiety-like, dysphoric, aversive, and drug-seeking behavioral responses. But some papers say it does not cause drug seeking. In fact, they say it decreases drug-seeking behavioral responses. But in practice, we have seen so Purdue Fredericks, like Mondi Pharma, right, in India, same sister pharmaceutical company, they introduced this oxycodone and oxycontin. When the MS contin, like long-acting morphine, patents were going, they introduced nicely this oxycontin. Obviously, it's a smart thing to do for them because they're losing patent. Let's bring this in. And that's when we started seeing problems because of the kappa effect. It has abusive potential. So though you probably heard or in news about OxyContin abuse, and now the government is suing pharmaceutical companies here big time because all the opioids that are used in cancer pain, they extrapolated for use in non-cancer pain. That's when this whole opioid epidemic problem started in the United States. So this OxyContin was very, very popular. It was introduced and one of the highest prescribing drugs, but it has these issues. And the people have, you started using it, became a good street drug with high cost value and things like that. And again, oxycodone is 1.5 times more potent than morphine. Effect is 40 to 1 hour of administration, lasts for 12 hours, long acting formulation, and plasma half-life for short acting is 3 to 5 hours of that of morphine. Oral bioavailability is good. That's why it's popular. It's almost 60 to 80% is available orally. The two main metabolites are oxymorphone. Remember, we just saw oxymorphone as a drug, which is a very potent analgesic. Right? And this is 3 times more potent than morphine. And then normoxicodone is a weak analgesic. These are the metabolites. So this is oxycodone, again, very popular, very commonly used even now, both long acting and short acting as an alternate to morphine. But it made a lot of money to the company, but it has kappa effect. It does produce that, in my opinion, yes, drug seeking behavior, that euphoria it causes. At the same time, it causes anxiety, dysphoria. So for some reason, it became very popular and it's very, very commonly used currently in United States. I heard it's available in some states. It's available in Kerala. I have to ask Sunil whether they have used it or anything heard about it. But I was reading, if you Google it, it says that it's available in Kerala, Bihar, and a couple other states. Or maybe other reasons, but not for cancer pain. I don't remember that it's approved for use in pain. I don't know,
No,
Sunil.
oxycodone is not available.
Okay. It is available in intravenous also, not in United States. In Australia, they use it intravenously also. I'm sure some Australian speakers who come to India yearly, they can tell you better about intravenous than I do because we don't have it. I've not used it intravenously. So we already talked about metabolism. This oxycodone undergoes 3A4 metabolism and converted into normoxicodone. It's a very inactive or weak analgesic, but 19% undergoes this 2D6 and becomes oxymorphone. So all the drug interactions you need to be aware of, even for oxycodone. So if you give inhibition of CA3 with antifungals and antibiotics, some of them, it reduces formation of normoxicodone, CA3, because you inhibit this. But at the same time, since you are inhibiting CA3/4 with these drugs, it increases exposure to other 2D6, which forms active oxymorphone. It's only 90%. This is more than this. But if you inhibit this 3A4 with antifungals and antibiotics, it shifts to 2D6. And that's when it becomes very active. So that's when the blood level goes up too, like we have seen with methadone and other drugs. So something to remember about oxycodone. You're not using it, so you don't need to worry, but just to be aware. Tramadol, I want to put it tramadol here because we use so commonly in India too. I've seen tramadol being used. It has many metabolites. Again, it is phase 1 metabolism. It is not conjugation in the liver. So you really need to worry about drug interactions too. Okay. So it is 2D6 again metabolizes it to O-desmethyltramadol. It acts on the mu receptors, and 2D6 expression is variable, but mostly it's metabolized to active, which works on the mu receptor. But it's a partial agonist, like you said. It's not a potent analgesic. A partial agonist. It also has a serotonin and norepinephrine reuptake inhibition. So that's why we use it as a combined drug for this. And tapentadol, which is a derivative of this, has weak norepinephrine but more mu. So that's why it's become a little more popular than tramadol. Serotonin syndrome need to be aware of when you're using with SSRIs, antidepressant drugs with tramadol. And seizures are described with this. And especially the risk is pronounced when you administer with CA4 inducers, such as carbamazepine, or with selective serotonin reuptake inhibitors, tricyclic antidepressants, or medication with additive serotonergic effects. So all these drugs can raise lower seizure threshold, especially when you use tramadol. You need to be aware of this phase 1 metabolism and can raise the active component and cause seizures. Hypoglycemia, the case reports of tramadol causing hypoglycemia is a 3 times more risk of hospitalization for hypoglycemia with the tramadol. So something to be aware of. Okay. So tramadol is not a benign drug like we think it is. So remember, it is used with caution. So these, I just put a table to highlight the major metabolites of different opioids. Morphine we already talked, hydromorphone we talked, oxymorphone we talked, levorphenol. You don't need to worry about 2, 3, 4. Fentanyl, norfentanyl can be active but mostly inactive. That's why fentanyl, they say, is the second best drug in renal failure. First is methadone, of course, has absolutely no active metabolites. Then oxycodone has these metabolites. Codeine, we talked about codeine and how it can behave and how it is metabolized. Hydrocodone, again, 3A4, 2D6. Meperidine also, the pethidine that you use, and then tramadol. And normeperidine, again, a seizure producing substance. We don't use meperidine anymore. And tramadol, again, O-desmethyltramadol. These are the metabolites, these are the enzymes involved. So you need to be aware of. So you need to worry about morphine, fentanyl, codeine, tramadol. This is a dosing table. I'm not sure it's useful, but you already do it. But I put all the opioids, how they compare to morphine. Any questions so far? Let me finish these 2 slides and then we'll take questions, because my thought process. Let's so opioid metabolites which are active. So codeine is converted to morphine, C6G. Norcodeine is a weak, but these 2 are active. Morphine, M6G and M3G are both active. Oxycodone, oxymorphone is active. Meperidine, of course, meperidine, there is a long half-life. That's why it causes all these issues. Then hydromorphone also is active. These are the opioids which produce active metabolites. Inactive metabolites, fentanyl is inactive, methadone inactive, oxymorphone, mostly it's inactive. So they're pretty much useful in the renal issues. Okay. So any questions on that? I'll stop here and take some questions.
Sir, this serotonin syndrome of tramadol, what you told, should we be cautious while giving? Some patients are on duloxetine or venlafaxine.
Yes, yes. You need to be cautious, of course. Yeah. Yes.
Does it hold true for patients on tapentadol also?
I don't have much experience with tapentadol, but it does have weak effect also, norepinephrine, not much on serotonin. So little more okay to use tapentadol and not worry too much about, using SSNRIs and SSRIs and all that. But tramadol, yes, for sure.
Okay, sir. Because I had like recently started a patient who was on duloxetine on tapentadol. So
Okay.
now I'm like worried, should I be?
Not as much as if you did tramadol.
Okay, sir.
That's why it is popular, because it's less effect on serotonin.
Okay, sir. Thank you.
Anything else so far?
Yeah. Some guidelines suggest hydromorphone for patients with CKD. So, how that,
What? Sorry.
some guidelines suggest hydromorphone for patients who has chronic kidney disease than to morphine. So,
Yeah.
what's
We-
your take on that?
I know this is a good discussion, but remember we talked about morphine, 2 active metabolites, and hydromorphone, only 1 active metabolite, which is excitatory mostly. So in terms of if the patient is experiencing excitatory side effect, for example, delirium, myoclonus, things like that, then both are bad. But if you are using it for sedating side effects, okay, if the morphine is causing a lot of depression kind of effects, then hydromorphone probably is better. Yeah, that's why there are a couple of papers which compared morphine to hydromorphone, and they noticed these side effects less in hydromorphone group. So that's why they say in renal failure, if you have both drugs, morphine and hydromorphone, you probably will pick hydromorphone. That doesn't mean to say morphine is completely contraindicated, but you have to reduce the dose. Yeah. Probably the best drug is methadone, of course. Yeah.
So if you have fentanyl, methadone, and buprenorphine, which one would you select in patients with a chronic kidney disease?
Methadone.
Oh.
Yeah, methadone has absolutely no active metabolites, but you have seen fentanyl when you give high doses. We are all anesthesiologists, we have seen high doses. It can still cause delirium and seizures. Fentanyl, even though we say that it can be used safely, I agree, it can be used safely in renal failure, but fentanyl itself lingers around and they can cause issues. So I prefer methadone in a kidney. That's a drug of choice in renal failure patient.
Okay, so I was writing a document on analgesics on renal failure, but I read that 90% of metabolites of buprenorphine is excreted through bile, or almost all of metabolites through bile. So they say buprenorphine is the first choice. Then they come to fentanyl. Fentanyl, I'm not sure how much it is excreted through the renal route, but methadone, 20% is excreted renally, and that's what they say. So
But it has no active metabolites though. It has no active metabolites. Yeah, so that's why I prefer that. Fentanyl, we have seen problems with fentanyl also. Even though they say that, I know it's a lot of inactive metabolites. I prefer methadone, fentanyl, and maybe buprenorphine.
Okay.
It is still, the evidence is not very clear cut on this, to be honest. I think there need to be a lot more work. People with renal failure, there are unanswered questions. So a lot of unanswered questions. For example, how much dose you decrease based on glomerular filtration rate and things like that. So they're not very clear.
Yeah.
I also struggle teaching this to students. Opioids in renal failure, because they're not clear cut. If you look at different papers, they tell you differently. But I think generally what I read from all these papers is generally methadone, fentanyl, and buprenorphine are okay in renal failure patients, and others are relative contraindication. Morphine, hydromorphone may be next, oxycodone may be okay, but morphine they always put last, right? But it doesn't need to be. You can reduce the dose, but how much we don't know. But that usually takes the hit, morphine. Of course, codeine, morphine, and other stuff take the hit. But fentanyl, methadone, that's what they talk about. Buprenorphine, fentanyl, methadone are the safest. I don't say completely safe, but they are supposed to be safe that for the doses we are using clinically. Yeah. Methadone, I have very good experience with. We use methadone quite a bit, as you know. We are probably the highest methadone users in the world, if I may say. We have excellent experience. That's what we reach out for. If there's no contraindication, for example, methadone has other issues, right? It's like opioid, it can cause other side effects too. Plus, there you have to remember about QTC interval with methadone. So because of QTC, people probably prefer fentanyl and buprenorphine. That's why methadone takes a hit, goes last because of QTC issue. But again, if the QTC is normal, the altered renal function situation, it's a good drug to use. I think QTC is a little bit overblown, in my opinion. Methadone and we get scared of using methadone because of QTC, right? I mean, correct me if I'm wrong. India also started like that. Very, very cautious. I think you need to be cautious, no question about that. But we are overcautious, I think, in my opinion.
Yeah, when we started the methadone, when it was available in 2018, we started methadone only in 8 patients. But now we have about, I think, more than 50 patients on methadone.
Yeah, I mean, you see how good it works, right? I mean, why would you put on?
Yeah, definitely. We have seen wonders with methadone.
Tell me about fentanyl. I'm really not satisfied with pain management with fentanyl. I know we are anesthesiology, we use it frequently, but fentanyl is, I personally am not too keen on fentanyl, other than situations where, you need fentanyl patch sometimes, as a long acting for convenience. We use it. Other than that, parenteral fentanyl, it has its own issues, and and it's expensive, and you have to infuse, So methadone can be given by any route. So that's why you need to consider that aspect too, the practical aspect about these opioids. So, and methadone is cheaper, I'm pretty sure, compared to fentanyl, especially fentanyl patch. And if you compare methadone to fentanyl patch, it's a lot cheaper.
Yeah, it's methadone is almost equal to morphine. And fentanyl is maybe some 100 times more costly than methadone and morphine.
Yeah. Yes.
I think Punita has a question.
Okay.
Sir, I want to know more about nalbuphine and naltrexone. Like nowadays in India, it is available now, sir.
Yeah. I mean, they're antagonists, really. I mean, you don't need to worry too much about them. They're useful sometimes.
Okay.
Sometimes, there's a lot of research on, using it with opioids to prevent constipation,
Sir, about your experience with these drugs?
We give mostly nasal naloxone now to people who are on combination medications, opioids, some sedating drugs like benzodiazepines, and especially gabapentinoids, gabapentin and pregabalin. If they're on this, then we give a ampoule of nasal naloxone to families if in case they overdose. Other than that, they're antagonists. They are there. In cancer pain situation, not very useful. And to prevent constipation, No, if you do other things properly, the laxatives, you don't need naloxone. People use naloxone sometimes to treat intractable constipation, but I've not used it. Never had to use it.
Okay, sir. Thank you, sir. Sir, and about buprogesic in acute pain like post-op pain or sudden increase in pain, buprogesic patches especially,
Hmm.
it will like post-op analgesia. Many people are using buprenorphine patches, no sir, as anesthetist. Many people are prescribing.
Hmm.
What is your opinion on that, sir?
Believe it or not, I do not have experience with buprenorphine. Our institution just started using it, buprenorphine, because it's getting very popular here as an alternate to methadone in opioid, or drug abusers to prevent, drug abuse. But as an analgesic, we are exploring, and some institution here use buprenorphine a lot. I know India uses a lot. When I heard from Dr. Rajgopal, sublingual buprenorphine was used a lot in India. Right, Sunil, correct me if I'm wrong. Patches are available. The problem with the patch is once you put on a patch, it's a long half-life. So I'm not sure you're justified using patches in post-op situation. It's going to be very difficult to titrate. I know for the lack of any opioid or afraid to use morphine or other opioids, we just use buprenorphine. But buprenorphine patch is not ideal for post-op pain. If you really have to use, maybe I use sublingual. It's a PRN and works for a few hours and done with, to 6 hours and done with, and nice there. But buprenorphine for post-op pain, in my opinion, is not justified. And I don't know, anybody in a group used buprenorphine a lot. I can learn about that a little bit here, about buprenorphine. But like I said, for post-op, I don't think that would be useful.
Okay.
Knowing buprenorphine, what it is. So please, others chip in. I'll be happy to take your knowledge about buprenorphine.
Have
So
you
the
used
buprenorphine,
sublingual buprenorphine? Have you used, sir? For what dose should we start with?
It depends, right? I mean, you can usually people start with sublingual is 2 milligrams.
Okay.
Yeah.
The same injection preparation what we have, we use like the one we have is like 300 micrograms or something. We'll get 1 ml. We'll have 300.
0.2 milligrams. Sublingual 0.2, 0.3 milligrams. Is that right?
Yeah, that's right.
Okay, that's a low dose, but yeah, sure. Like I said, I don't have much experience with buprenorphine.
Okay. We add a lot of this in spinal. Most of the spinal anesthesia we add buprenorphine for post-op analgesia.
Okay. And
so the buprenorphine patch available in India are 5 milligram and 10 milligram. So the 5 milligram patch, 5 milligram patch and 10 milligram patches.
Okay.
The 5 milligram patch is equal to 12 milligram of oral morphine per day, and 10 milligram is equal to 24 milligram of oral morphine per day. So I don't believe in buprenorphine patch because that is the strength of the patch is very, very low. And as you told, the titration, what can be done if a patient has more pain? It is not a suitable drug for patients who has acute pain. And many of the patients may not be even knowing that it will take maybe 24 hours to analgesia, and nobody will have the time to teach this to patients, and probably patients will remove the patch after some 10 or 12 hours. That's what usually happens, and many patients come to us telling that this is not giving any pain relief, so we remove the patch also.
Yes, that's the issue with the patch. For example, you don't really use acute post-op pain fentanyl patch for the same reason, right? I mean, it takes almost 18 hours to kick in, and then you can titrate and all that. But tell me about buprenorphine in cancer pain, Sunil. I know your team uses a lot of buprenorphine, but like I said, we just started using it. We are educating ourselves on.
We are not using buprenorphine. I think we are not using it at all. I used buprenorphine during 2005-6 for a few months. but thereafter I have not used buprenorphine till now.
See, the issue with buprenorphine, theoretically at least, is it's a partial agonist. Very potent. It replaces, a lot of other opioids, so it can cause antagonism sometimes and precipitate withdrawal in people who are already on opioids. But again, some people claim if you use it as a first line, we start with that. Maybe a low dose patch is what you need in the cancer pain. Like you said, 5 milligram patch, or including 2 milligram, we have 2 milligram, very low dose to start with. Then you can add other short-acting opioids as a breakthrough medication. Patch is a long-acting, and or maybe you only need patch sometimes. But if you really need breakthrough medication, then you can add other short-acting opioid to buprenorphine. That's what we are doing right now, and we are studying on it. Apply a patch in people who have not been on opioids to start with, and then give other opioids if needed. So some centers have a lot of experience with it. But like I said, I'm not that keen on it for various reasons, for the reasons I talked to. But it is pushed a lot here because it is used replacing methadone for opioid use disorders. That's what buprenorphine is used the most because of long half-life, right? Patch, work for 7 days. You change only every 7 days. It's a very convenient, and it's a good drug for that reason. As an analgesic, it can get a little dirty, buprenorphine. So it is a partial agonist. But it's an interesting drug, though. Some people get, when I visited, Trivandrum long time ago, they said sublingual, like 0.2, 0.3 milligram sublingual, we provide great pain relief for 6 to 8 hours. And people swear on that, that it's a great analgesic. But the titration is an issue, going forward, like other opioids. When the cancer pain is always changing, you need, there are frequent breakthroughs and things like that. So does buprenorphine fit there is a question. I'm sure some experienced people who used it a lot, who developed art of using buprenorphine, can tell you that it's a great drug too. But I mean, when I use a lot, I'll come back and tell you my experience, but I have to depend on Sunil and all of you to tell me how buprenorphine works out in cancer pain. In fact, that will help our group because we are just starting that now.
So I use it in patients who need low dose morphine.
Okay.
So that the 4-hourly dosage can be mitigated, and the patch itself is enough to control the pain. Especially, sure. I had patients with oral cancer who have difficulty in swallowing the tablets. So once it controls, with low dose morphine controls the pain, and we convert it to buprenorphine.
How much patch do you start on?
I usually with say 5 milligrams morphine Q4H and 10 mghs, I get a very good pain relief with 10 micrograms per hour, which can be changed. So we have in 5, 10, and 20. We have all the three. So I usually start with 10, and 10 is enough for very, very beautiful pain with very low side effects.
Okay,
and
10 micrograms.
Yeah, 10 micrograms per hour.
10 micrograms per hour. That's right. 10 micrograms per hour. Got it. Yeah, so that situation, people who have low grade pain, who are controlled by low dose morphine, probably useful in head and neck cancer patients who don't have to swallow too much, and that's useful. Okay, yes, very good, thank you. And how do you compare cost buprenorphine to fentanyl patch to morphine?
Fentanyl and buprenorphine, microgram per microgram, it is almost the same. Because the 10 micrograms, it costs about, I think, 400 rupees. Okay. Fentanyl also costs about 60.
No. Buprenorphine patch, it comes as a pair, and it costs 1,920 per pair.
Actually, sir, I'm getting it much lesser in our place. I don't know why, but one of the companies was giving us for 400, I think the 20 was 800 rupees.
I see.
Yeah.
Then fentanyl is pretty similar, is it?
No, fentanyl is a little more costly, sir. Fentanyl I think 25 is about 800 and 50 is about 1,600.
So they're both expensive compared to other opioids.
Yes,
Looks-
definitely expensive compared to morphine. Sir.
Got it. Okay. Okay. So probably that's why they didn't pick up, like Sunil said, they don't use it. But in some situations, maybe it's a good to have. Okay. All right. Any other discussion so far?
Sir, excuse me, sir. You told about this hypoglycemia with this tramadol, no, sir? Have you seen any?
I've not
patient?
personally, I've not seen any patients going to hypoglycemia. There are only case reports so far, but something to be aware of.
Okay, sir.
Keep on back of your mind. Sometimes we miss things and rare occurrence can happen, but it's been reported though.
Okay.
We all get excited with rare things in life. This is one of those.
Okay, sir.
I think a little bit about methadone. Sorry.
Sir, now with morphine and methadone and whatever is available in India, do you think getting any other drug here will make a big difference? We already have morphine and methadone.
That's a very good question. Okay. I think you have to consider so many factors when we advocate a drug in India. Cost is the main issue here. And also the usefulness. I mean, even if the cost is not an issue, the usefulness of the drug. I would probably think hydromorphone will be useful if at all it needs to be introduced. Others probably are not. Oxycodone, no. Oxymorphone, no. Maybe hydromorphone, maybe, because it's a little more potent in situations where morphine is not working out. You can use hydromorphone as a alternate medication. So only that drug I would think may be useful. And livorphenol, if it is available and on a comparative basis, and if somebody is willing to manufacture, and if it is approved in India, which is a long process, okay, I've seen with methadone, it's a long process. That might be a good addition to India. So hydromorphone, I prefer levorphenol first and then hydromorphone. These two drugs might be useful. Other than that, other drugs probably not.
Thank you, sir. Sir, and about this fentanyl lollipop or something, I have not used it, but
Yeah.
do you have an experience or will you suggest it?
Yes. I did a small research and I had to abandon it. So you can forget about fentanyl lollipop because it has a lot of issues. It's very expensive, number
Okay.
one, very expensive. And number two, it gets into the system so fast. And it will become that's why they name it lollipop. People, when they feel like having sugar, you eat candies, right? So when they feel like having high, they use fentanyl lollipops. So I don't think it has any place in cancer pain management.
Okay. Can
So,
fentanyl be also abused like morphine, sir?
oh yeah. Now the most number of deaths caused in the United States are because of fentanyl, street fentanyl. Of course, high potency fentanyl. Of course. In fact, people were extracting fentanyl from fentanyl patches and injecting themselves. But now the patches are made differently, right? They are impregnated into the structure itself. So they can't extract, but people used to extract that. Absolutely. Fentanyl is a very abusive substance. A lot of anesthesiologists are addicted to fentanyl. You know that, right?
Yeah.
So a lot of anesthesia residents and all, because they try as an experiment, one dose, let's see what happens, kind of, because it's a lot of boredom, right? So inject one time fentanyl and they feel good about it because they use under stress possibly. And then that's it, you get hooked. Like pethidine. Fentanyl is a notorious drug. Yes. High addicting potential.
Is there any role for pethidine in current situation, sir? Now?
Pethidine as an analgesic, no. But we still use in post-op situation where there is shivering. Right.
Okay.
They use a leukemia group uses the same thing for shivering. Other than shivering, that no role for pethidine.
Means like during chemotherapy they give pethidine?
the chemotherapy, there are shivers and rigors and all, they give pethidine, PRN, as needed. That's the only use for it. And in the post-op, we use it. Post-op, when the patient are brought to the recovery room, they're shivering, right? Sometimes, and
Yes.
we use 25 milligrams of pethidine, and it stops it. Otherwise, for analgesia, we don't use it because of the problems you have seen, right? It has active metabolite, and metabolite has a long half-life. It does accumulate and cause seizures and other problems. So that's why we don't use it.
Still, for labor analgesia, we are using pethidine in our hospital.
Yeah, I think
2020.
it's a short term, right? So possibly okay.
Okay.
But I don't know why it's a favorite drug
For gynecologists.
in colleges. God, I've seen pethidine being abused in the labor ward. I've seen
Okay.
people used to steal pethidine from. It used to be open, right? Kept openly. I have seen physicians inject pethidine, coming to the labor ward at odd hours, taking it and injecting it. It can be a very high abuse drug. Yeah. But I mean, it's, it works.
Nowadays,
And
Opioid addiction only I have seen among healthcare workers. Like whatever my personal experience is, Opioid addiction.
Fortwin, sure.
Because they don't keep it in the lock, like along with fentanyl. It comes in a plastic like snap of ampule, plastic ampule. It comes.
Yeah.
30 mg of Opioid. That abusers were there. At least I have seen.
You find abusers for anything in this world, especially opioids, of course, some opioids, but people are addicted to kerosene and petrol.
Okay.
So, I mean, if you are available openly, freely, and then people want to alter their mind, which gives them good feeling, right? All right. For some reason, I can't proceed. I don't know what happened. Let me see. Let me see. I don't know what this is. Just froze. Do you think I can stop sharing and share again, Sunil? Will you help me?
Yes.
Okay, share again. Methadone, just thought I'll put it for fun's sake. You all know, excellent bioavailability. That's why IV and oral, you don't have to change the dose. Sometimes people use it 1:2 when you go from IV to oral, but because of the high bioavailability, but it's variable though. So it's better to be on the cautious side anyway. Absorbed well, start acting in 30 minutes, beautiful. And then, but it takes to come to steady state, it takes, almost 2 to 3 days. So you need to be aware of that. And analgesia can be long lasting. We start with every 12 hours as as a schedule. It is used as a long acting. Metabolites, inactive, but it is by cytochrome system. 3A4 is the main one, 2D6, 1A2 also. No active metabolites excreted via fecal route. Safe in renal failure, preferred agent for us. Others are fentanyl and then hydromorphone. Buprenorphine, if like Sunil was saying, is good in renal failure patients also. So these three, buprenorphine, fentanyl, and methadone. So you can fight which is number 1, 2, 3. These are supposedly safe drugs in renal failure. There you go. So the metabolism is again, it is active metabolite. It's cytochrome P450 system, 3A4 and 3A5, with a contribution from C8 and C9. What are the implications? I don't know about the drug interactions and things like that. Like I said, I've not used it, and we are slowly dwelling into it, the details of buprenorphine. Not much experience. This is mostly from reading and listening to other people. So I don't know what to make of this, but it is metabolized by cytochrome system, not by phase 2 metabolism. Okay. So we'll keep tuned. We'll get back with that. And these are some of the 3A4 inhibitors, where if you give methadone with other drugs, the level of methadone goes up because these drugs inhibit 3A4s. So we call 4As. I mean, I'm sure you already had this slide before, somebody showed you when they talk about opioids. Amiodarone, antiarrhythmics, antidepressants, benzodiazepines, antimicrobials, antiretroviral, ketoconazole, ciprofloxacin, azithromycin, alcohol. Okay. So alcohol is funny because in acute situation, it's inhibitor. In chronic, it's inducer. So when you induce this enzyme, that means a lot of methadone is metabolized. So you need higher dose. In chronic alcoholics, you need higher dose of methadone. And we have seen that while doing anesthesia. God, this guy is taking a lot of, opioids. And then we discovered that he was chronic alcoholic because if they induce enzymes, you develop tolerance and you metabolize drugs very, very quickly, fast. So these are the inducers. Okay. Methadone, barbiturates, carbamazepine, antifungal, and some of the anti-epileptic drugs, including dexamethasone, they're the inducers. So these are the inhibitors and inducers. I just wanted you to be aware of that, because now we have learned about phase 1 drugs with the interactions, and you need to be aware of these drugs, which are inhibitors and inhibitors basically raise the level of methadone and other drugs. Inducers, not effective. You need to give higher dose of methadone, basically. Okay. And, we never use these medications like you're mentioning about nalbuphine, pentosacin, buprenorphine. They demonstrate ceiling effect. They precipitate withdrawal. They cause psychomimetic effect. But respiratory depression is not common with this drug. That's why buprenorphine does not cause respiratory depression. So probably safe. Now, buprenorphine patch, like mentioned, probably useful in some situations. So I will stop there, Sunil, and see if you have any final questions. I know I took a lot of your time. It's okay for me because I'm just getting started here. It's getting very late, and I apologize for that. And I'll be happy to take any questions.
Anybody?
So what is your experience in using subcutaneous continuous infusion of morphine?
Exactly same as intravenous. No difference. Absolutely. Yeah. Because United States is a little funny. Like I said, it's all insurance-based, insurance approved and things like that. In the hospitals, they always want us to use IV, but no reason at all. Subcutaneous IV work exactly the same. In fact, for the home care, that's the best.
Yeah, we use it for home care.
Sure. Works fantastic. No reason to put IV or anything like that. Just leave butterfly needle and this plastic cannula, tape it. You can use for 1 week to 2 weeks, really, if you're careful. Nice.
We use it with the butterfly needles.
Butterfly, okay. No problem. Equally good. But we use, what we do is we put that plastic cannula, channel it and leave it there. And you can do that too. Just thread the sleeve inside the fat, and that's it. Works same.
Sir, is there per rectal use of morphine?
Morphine, methadone, and most opioids can be used by any route. You can prepare suppositories of morphine, suppositories of methadone. So rectal route, all these medications can be used. There's a lot of rich arterial supply. So you can make a good case for rectal use. A lot of it is absorbed. In fact, you can, bypass that first metabolism in the liver, sometimes people say. So the rectal route is excellent. In patients, you're not able to get access to anything. Yes, rectal route is sometimes uh, you know, underrated and underutilized. But people don't prefer that route. But if you can, yes, it's a great route. Sometimes we forget about it.
Should we reduce the dose if I'm
Yeah,
using?
you should reduce the dose a little bit. Yeah, definitely.
The same oral drug can be used rectal form, sir, or any other.
I think you need to talk to pharmacists. They make a suppository kind which diffuses slowly in a capsule form. But in a worse situation, you can use the same medication rectally, yes. And you can use vaginally too, the same medication that you're taking orally, you can put it. But thing is, they don't stay. That's a problem, you know.
Okay.
The technical problems, other than that, I think if you talk to pharmacists, they'll be able to make you nice suppository for you.
Fine.
Actually, for a nurse's mother, I used the oral tablet only as per rectal. She was esophageal cancer patient.
Okay.
10 mg morphine,
Yeah.
4 times daily, but 4 times she couldn't like come home and do, like only the daughter had to do it. So she started giving it thrice daily or twice daily, but still it helped.
Yeah, okay, of course it does. Like I said, it has excellent, arterial circulation there in the rectum. It gets absorbed very nicely. Yes. Possibly helps with at the same time constipation too. Sometimes stimulation does improve bowel movement, so it serves both purposes.
So the oral drug should be made into a paste, or directly the tablet can be placed for rectal if we don't have any suppository form.
No, you can
So-
place like you heard the tablet can be placed directly.
Okay. Okay.
Yeah, you can place tablet directly in a situation where you're not able to get access to any other route. This is the best route.
Yeah,
So you
what
can-
we did was we like wet the finger, like gloved finger, make it wet, and
And you need to
until
do
the
high.
index finger goes, that depth I asked her to insert.
Yeah, you need to insert it little higher if you
Okay,
can, as much as you can. Insert it higher, then it stays. The problem is it slips out. That's a common problem. But as long as you keep it a little high, then it stays.
Okay, sir.
So you said you have a lot of experience with methadone. In an opioid naive patients, how much will you start with?
You can start with 5 milligram twice a day. Even though some people are scared with that, there is a paper by Dr. Eduardo Bruera as a first line, methadone as a first line drug for cancer pain. You can start with 5 twice a day, but that may be a little much for some people. So you can start with 2.5 milligrams twice a day. Yeah. That's a safe dose to start. But 5 twice a day also is safe, but they may get a little sedated to begin with. So that's why people prefer 2.5 twice a day.
And you said the steady state will be achieved in about 2 to 3 days.
2 to 3
So
days.
if you need to increase the dosage, should we increase it only after 3 days?
Yes, that's the big discussion. Some people say 3 days, some people say 5 days, but don't increase every day for sure. Yeah, ideally every 3 days,
Okay.
not touch before 3 days. And use breakthrough in between if you have to.
Breakthrough with morphine?
Morphine.
Sir, if we have to convert that first line methadone into completely morphine, then how would we do from
Yeah.
methadone?
It's a very, very good question. So methadone, we know from morphine to methadone conversion, we know it's 1 to 10, 1 to 15, 1 to 20, depending on the amount of morphine, right? But from other opioid to, from methadone to other opioid, for example, from methadone to morphine, there's not much literature. It's not the same factor, okay? So it's not bidirectional. It's different when you go from methadone to morphine. So it's 1:5. One of our colleagues did paper on that. So for every 1 milligram of methadone, you use 5 milligrams of morphine. So that's the ratio we use. Yeah, it's a little different. You understand?
Yes, sir.
For example, if somebody is on 100 milligrams of morphine and to convert to methadone, we use 1 to 10 and maybe
Yes.
cut down by another 30%. But you go from, if somebody is on 10 milligrams of methadone, so how much morphine do you use? 5 times than that, 50 milligrams. So that goes to, you can divide it in a long acting or a short acting, whichever way you want.
Sir,
10
I will say the 10
for
mg
times.
methadone is equal to 50 mg morphine.
Yeah, something like that.
Thank you, sir.
That's the only paper we have. Again, more research needs to be done that way, like, from other opioid, methadone to other opioids.
And sir, when we use ADNOC, the buprenorphine sublingual tablet 0.2 mg, so we every 12 hourly, and how would we escalate the dose, and what co-analgesics can be safely given and which to be avoided?
That is a question to Sunil and other experts in India.
I am also not experienced, so I don't think.
No, actually, sublingual, I heard you can use like a 0.2, 0.3 milligram sublingual every 6 hours as needed, because it does not work for more than 6 hours, right? And then if you are using that as a breakthrough, you probably don't need any other opioid. But if that's not working, I prefer that you go to other opioid completely instead of buprenorphine. And buprenorphine long acting, for example, buprenorphine patch is safely used with morphine as a breakthrough medication in between. Okay. So definitely, like Dr. Biju said, you can use a patch, 5 microgram an hour or 10 microgram an hour, and add, morphine to it as needed, every 4 hours as needed. But when you're using sublingual, which itself is a short-acting medication, I prefer not to add any other opioid to it. If you're not getting control with sublingual, then I prefer you go to completely some other opioid.
So that's what we do. So when we use some buprenorphine and we don't get control, then I change it completely. I don't add.
Right. Or change completely to other opioid. Yeah. Better.
Thank you.
Thank you.
Any more questions?
Sir, it is not opioid related question, but how the ketamine infusions which we use in the cancer pain, that I would like to know. It's not opioid, but
The infusion of opioids or any infusions?
ketamine infusions.
Ketamine?
Yes, sir, ketamine infusions.
Yeah. There is okay. If you have to use ketamine infusion, again, that's not many people use ketamine these days. But if you have to use, and if your center is using, I would not use more than like 0.5 milligram per kilo. Okay. Maybe less than that per hour infusion of ketamine. Total, I would like to say, start with 25 milligrams in 24 hours, then gradually increase that to 30, 40, 50 milligrams in 24 hours and convert that into per hour. That's how much I use ketamine. But I'm not used ketamine in a long time because of methadone, because ketamine is NMDA receptor antagonist and methadone does the same job. So there was no need for me to use ketamine. But some centers do, some palliative care units do, but it also causes sedation and dysphoria and things like that. So it's not a clean medication like we think it is. So I've not used ketamine in a while, and I don't know anybody has any other experience with ketamine. Sunil and team.
Yeah. So we sometimes use ketamine. It's mainly for chronic non-cancer pain, and usually we start with 25 to 50 milligrams per 24 hours, and then titrate according to the side effects and pain relief. Usually it is given for 5 days, and then we will see whether we can stop it or do we need to go to some other medications or interventions.
25 to 50 milligram in 24 hours. Yes, yeah, that's what it is. You can give IV subcutaneous infusions. Yeah.
Sir, I
yeah.
have experience in using ketamine for non-cancer pain again to reduce central sensitization or neuropathic pain. I also do the same thing, 25 milligrams. I put in 500 ml saline or 250 ml, like half the bottle of saline, give it over 1 hour. Like that, I give PD or TID, too much, how much ever they tolerate. Sometimes I used to pre-medicate this with either benzodiazepine or with clonidine for to avoid the dysphoria. But with 50 mg, whenever I gave, some patients get distressed, some people sweat. So 50 mg did not work out for me for 2-3, like some fibromyalgia patients I've given. And then I also read a paper, like even magnesium infusions like this are used for NMDA antagonism.
Yes. Yes.
And similarly, lignocaine, IV lignocaine. For to
If
avoid.
you go into evidence of all these that you mentioned, maybe magnesium, I'm not sure, but ketamine and lignocaine infusions, the evidence is not great. There is a paper by Australia group, David Caro and others, which did a meta-analysis on ketamine infusions. Not very encouraging about that, especially in cancer pain. I'm sure, based on your experience, and you got great relief in some patients, you use it. But generally, for cancer pain, ketamine evidence, I used to believe ketamine a lot, but lately we have noticed that it is risk versus benefit, more risk than benefit from ketamine. But if you really have to use it, that is how one uses in India looks like. Yeah. Thank you.
Sir, about lignocaine and magnesium infusions, do you have any?
Yeah, lignocaine infusions I used to use a lot. But again, same thing. I did not find it to be that useful. Plus, the evidence is not there for these infusions. I used to use a lot for neuropathic pain situations where to break the cycle and
Same thing I'm also doing.
Right, do a few infusions, and then we used to put them on this anti-arrhythmic drug. What is it called? I forgot now. Not used in a while. Mexiletine I used to put, but I've not used that in long time now. With the methadone helped a lot to change all that, I think.
So what is the usual dose you use with methadone?
Methadone I have not used, sir.
Oh, okay.
No, I am asking Dr. Suresh Reddy.
Oh, what's the dose of methadone for to start with?
What is the usual? No, up to if you take your patients, what would be the average dose of methadone they will be using?
Yeah. So one study we did, the average outpatient dose for methadone is really not more than 25 to 30 milligrams a day. Not more than that. You should be able to get good relief within 20 to 30 milligrams. That means with 15 milligram twice a day, that's all you need. Most patients, okay? If you're needing a lot more than that, then you're missing something else. You need to reevaluate. Yeah, I know some people use like 50 milligram twice a day. That's not good. I will not go more than like 30 to 40 milligrams in 24 hours. Then you end up with other problems.
Sir, I have a question to Sunil, sir. Like, to make more methadone available, should I have any other research? This RM other than RMI, should we have anything else?
No, you don't need anything else other than RMI. With the same RMI, you can also get methadone. Sometimes your drug controller may tell you that please give a request that you can do. Actually, as per the NDPS Act, you don't need any other license or anything else.
Okay, sir. Because my pharmacist told we have to show that we have an existing palliative clinic here or something like that. Some special request or something you have to write and give to.
You have RMI status, isn't it?
Yes, sir.
Then you don't need anything else. And I can connect you to Dr. Meenakshi, who's in Adyar Cancer Hospital. So as both of you are from Tamil Nadu, the things would be the same. So
Okay,
you
sir.
can talk to her. And
In Coimbatore, nowhere methadone is available, sir. Yes,
No,
Dr.
Dr. Punita, start using methadone. You'll be amazed how good it works.
Okay, sir. Sir, what is your experience of using methadone in non-cancer pain, sir?
I have to be very, very careful in using any opioid in non-cancer pain situation, because you will be getting into, other issues, dependency and all that. So unless it's really indicated, I would be very, very careful, especially in India, because it can become epidemic. So because of the gross numbers, so I would be very careful in starting opioids in non-cancer pain situation. And yet, if of course, if they're indicated and all, and you are watching them closely, that's fine. But you will end up with problems if you start using opioids for non-cancer. For example, chronic low back pain and neck pains and things like that, fibromyalgias and things like that. You have to be very, very careful, because all these pain syndromes have other issues. Okay.
Okay.
Chronic issues. Not that you don't want to help them and things like that, but you'll be creating a new problem.
Okay.
And
Sir,
this is from the experience here, I'm telling you.
okay.
You've gone through that path using
Have you seen methadone addiction, sir?
any opioid can be addictive. Any opioid.
Okay.
But it's a strong, good opioid for cancer pain because it has broad receptor activity, like you have seen.
So
It works on me.
So you said methadone does not have any ceiling, right? Ceiling effect.
No ceiling effect.
So
No.
then why did you say that you will not be comfortable
No,
with
any opioid, not just methadone, any opioid, I will not indiscriminately, increase the
I'm
dose.
talking about cancer patients, sir.
Methadone, because methadone has, remember, it prolongs QTC interval.
Yes, sir. Yeah,
So
but
that's
then again, isn't there a contradiction that when there is no ceiling effect and you are restricted in using it?
you can keep on going. Yeah, you can keep on going. The problem is, then the problem is that when you are going up indiscriminately on opioids, you're missing something else. We have seen this again and again and again.
Yes, sir.
So-
This is what happened in one of my patients, because I had a pancreas patient who was on almost 500, 600 milligrams of morphine and he was not getting controlled. And so I changed him to methadone, but then again, his methadone dose also going up to almost 90 milligrams. So I didn't, as you said, what would have been something which we missed, sir? I don't know.
Then you need to thinking about other issues like anxiety, depression, frustration, prognosis, family issues, economics. All these things come into play, as you know, in a cancer patient. So you need to address those issues. When every time you are escalating the opioid need for escalation, this is what we miss most of the times.
Okay.
And again and again we have seen. So the cancer pain management algorithm has changed completely. So every time somebody is on high dose opioids, it's a red flag and it's a signal that we are missing something else.
Okay.
We need to address those issues, spiritual issues, psychosocial issues, and things like that. You need to go back and assess those.
So you think mostly it is because of that rather than the actual pain itself?
Right.
Physical pain.
See, physical pain is there, no question about it, but see, it is amplified by other factors tremendously. It's amplified. If other factors are there, 1 + 1 becomes 12.
Yeah, it was quite puzzling because he used to get very controlled with a certain amount of morphine or methadone.
Yeah.
And after 1 week, then his wife calls and says he's in agony, and so what should we do?
Yeah.
So I told her I can't escalate more than this, and in that case we have to go for a celiac block and things like that. But the funny thing, as you said, now when you're saying that, then she said he got control with paracetamol.
Yeah.
So
what happens is, it's not anybody's fault. We concentrate on physical pain and we want to do our best to alleviate it. hey, I can't believe, and I want to make him better. It's like, you want to make him better, but your mind, it's all physical pain, right?
Correct.
And we have seen again and again, pain is not just physical, but a lot to do with emotions. Like I was showing that amygdala, that limbic system has a lot of role to play in amplifying pain. You see, so that's a new paradigm about pain management. So once you start doing that, but you need people. I mean, spirituality, chaplain, and address other issues. Then you should be able to control. So don't. It's not a battle that you're losing. I think you can't help every patient, but you're doing your best. But don't escalate opioids because you end up with different problems.
Okay. Just because there is no ceiling doesn't mean that you will keep on escalating.
See, I tell you example. The two same patients, like you described, maybe the patient is 60-year-old or something, 60-year-old patient, same pancreatic cancer, seen exactly same tumor on CT scans, nowhere else. One person responds beautifully to opioids, conventional treatment. Other person does not respond. Why? This, so that means
This was a puzzling thing for me because I couldn't put my finger on it. I said, I'm missing something. Probably, it's some other pain which is coming over, but could put a finger at it.
you think about it, right? I mean, patient is diagnosed with cancer, and patient possibly knows he's going to die soon, and possibly he has a lot of guilt, family issues, his enjoyment is gone, his autonomy is gone, and now the money is not coming, and then he's leaving behind kids, wife, and everything that he has done in life comes to surface because he's so much stress right now, there's so much guilt, and then he will be like cursing God, cursing this, cursing that. So that amplifies pain. There are unresolved issues in a lot of us. So you need to address those issues. That's why I think counseling, psychosocial issues, going into depths of this will help a lot. Besides opiates, in fact, sometimes those become prominent treatment. Opiates become very small, minuscule percentage of the whole management of pain.
In fact, that's what happened to him towards the last. They reduced the number of opioids, and he was only on paracetamol IV infusion.
Yeah. Probably they addressed all these issues. Either that, or he came to terms with it.
Probably, yeah. I think he came to terms with it because he died soon after that. But thank you, sir.
We all hold on to things, right? We have not done this. We're not done this. We have to achieve this. I have to live till my grandkid's birthday. I have to live. My daughter gets married. We all have these ambitions. Okay, they are not unfulfilled ambitions. So these play direct role in symptoms. These emotional aspects. So that's where palliative care is. That's the total pain concept is, right? That's the total pain. Yeah.
Sir, I have got a question with Sunil sir about, or Biju sir, whoever is using methadone more. Is methadone cost effective like morphine?
Same cost.
Same cost. It's lower doses of morphine when you convert to methadone. The cost would be same as that of morphine. But if you use a lot of morphine and if you convert to methadone, then methadone would be cheaper than morphine.
Yes.
Okay, sir. Sir, and being a beginner, should I always start with morphine, then change to methadone? Or sometimes if I could.
Yeah, I recommend that. Yes, I recommend that. Because even though methadone can be used as a first line, you should possibly go with morphine first.
Okay, sir.
Okay, I think this is a very interesting topic, and we may not stop because especially Dr. Suresh Reddy is very expert on this, and but we have to wind up the session. So I think we took almost 2 hours today. So thank you, Dr. Suresh, for this excellent session. Very interactive, of course. And thank you everybody for very active participation. And it's our to say here.
Thank you so much for everybody. I learned a lot again. Like I said, I learn every time I speak to my colleagues. I learn a lot. Thank you for highlighting me on buprenorphine, all the infusion that you use, which I don't use. And if I get more experience, I'll come back and we'll discuss more. Really, you made my day. Thank you all for joining, and thank you for your patience. I know it's getting late for you, and some of you probably had dinner already, and some of you have not. And sorry for keeping you away from dinner. And have a great night. Thank you, everybody. Thank you.
Thank you,
Thank you,
Dr. Suresh Reddy. Thank you so much for joining us. And we do wish that you have a very calm and peaceful day ahead, because I believe you are just going to start your day there when we are going to our beds. So thank you so much for joining us and enlightening us such a wonderful session. Thank you everyone for joining in. We will see you in the next session soon with another eminent faculty from another part of the world. Till then, everyone take care. Bye-bye.
Thank you. Bye.